Good afternoon. My name is Kelly Travis. Today, I will be presenting on improving appropriate use of benzodiazepines in adults at a community hospital. Today, we will discuss benzodiazepine safety standards and recommendations for best practice established by the CDC and FDA, describe my study design and discuss results, as well as identify opportunities for further improvement in benzo prescribing. Due to the severe adverse effects associated with benzos, their use is only indicated when a patient is suffering from a disorder that is severe or disabling. Benzos should be initiated at the lowest recommended dose and only prescribed as needed for a maximum of 4 weeks. A study looking at benzo prescribing trends over a 20-year period found that the number of adults filling a benzo prescription increased by 67%. The quantity obtained during this time increased by 140%. This means patients are being prescribed higher daily doses and more days of therapy with each prescription. As the graph illustrates, this change in prescribing patterns likely contributes to the more than four-fold increase in overdose deaths involving benzos. In 2010, benzos were involved in almost 30% of all pharmaceutical-related overdose deaths, second only to opioids, and data show that benzos play a role in almost one-third of opioid overdoses. Due to this, it is required that benzos and opioids carry a black box warning highlighting the risks of concurrent use. The purpose of my project is to identify benzo prescribing trends throughout a hospital system, promote evidence-based practice when using benzos, reduce the risk of adverse effects in patients prescribed a benzo, and assess the impact of an appropriate use guideline on benzo prescribing. Phase 1 of my study was a retrospective review that evaluated the prescribing of benzos in the inpatient setting. During Phase 2, an appropriate use practice guideline was developed and will be implemented. Post-implementation data will be collected to assess the impact of the guideline. Patients were included in this study if they had been admitted and prescribed a benzo between June and December 2019. Patients were excluded for the listed reasons. A total of 88 patients were selected and assessed with 127 benzos being prescribed, meaning multiple patients were prescribed more than one benzo during their admission. 46 of these benzo prescriptions were deemed to be inappropriate. These graphs illustrate the benzo prescribing trends seen. Lorazepam, alprazolam, and temazepam made up 78% of the total benzos prescribed. There were 5 prescriptions written without a clear indication. All 5 of these prescriptions were for scheduled clonazepam and were continuations of a home medication, but a clear reason why the patient was taking the medication was never established. Temazepam was only prescribed with an indication of sleep, which is appropriate due to this being its only approved indication. The only medication prescribed for nausea and vomiting was lorazepam, which is appropriate because it is the only benzo studied and shown to be efficacious for this indication. Of the total 127 benzo orders analyzed, 53 were ordered from a standard order set as PRN medications. 43% of these were never administered to the patient during their admission. The remaining 30 orders took an average of 2.8 days before they were ever actually needed by the patient and administered. This highlights how benzos have been overprescribed. Almost half the patients prescribed a PRN benzo never had a need for it. The almost 3-day lag time demonstrated in other patients suggests a clinical change occurred. When intervening with a previously unneeded medication, the patient's status change may be masked, leading to delays in investigating the underlying cause of the clinical change. This graph illustrates the reasons why 36% of the analyzed benzo prescriptions were found to be inappropriate, the most common reason being the initial benzo dose was too high. An example of this is a benzo-naive patient being prescribed 30 milligrams of temazepam at bedtime. The other reasons for inappropriate prescribing included starting a patient on a scheduled benzo without a clear clinical reason, discharging a patient with a new benzo that they were not on prior to admission, and prescribing a benzo for an inappropriate indication. An example of an inappropriate indication would be using alprazolam for sleep because it does not have an approved use for this and there are more efficacious options available. This graph focuses on risk factors that are known to contribute to adverse events when benzos are prescribed. The left axis, which correlates with the blue bar graph, represents the number of patients with each risk factor, while the right axis, which correlates with the orange line, represents the percentage of patients who experience an adverse event, defined as a fall or oversedation event. Overall, 71 patients received a benzo. Of these 71 patients, 31% experienced an oversedation event or fall. These 71 patients were divided into groups based on risk factors. It is important to note that a patient may be included in more than one group. So, for example, 42 patients were administered an opioid and benzo together. Of these 42 patients with this risk factor, 29% experienced a fall or oversedation event. The data shown coincides with previously discussed published data that the concurrent use of these medications should be limited due to the almost 30% chance of adverse outcomes. The data illustrates that age is the strongest predictor of an adverse event. Of the 26 patients who were over the age of 65 and received a benzo, 38% experienced an adverse event. Additionally, the graph highlights how the risk of an adverse event is significantly diminished if a benzo is prescribed appropriately or not prescribed at all. As shown, 7 patients did not have any risk factors and were administered an appropriately prescribed benzo, which led to a lower percentage of adverse events. In the 17 patients who never received an administration of their prescribed benzo, there were 0 fall or oversedation events. Again, this illustrates that benzos contribute to adverse events and should only be prescribed for patients when their use is clinically necessary, especially if the patient has additional risk factors. From the collected data, I was able to conclude that there is a need for a guideline that details the appropriate use of benzos. The areas where improvements will make the largest impact include reducing the number of benzos prescribed and decreasing starting doses. There are also opportunities to increase monitoring in high-risk patients in order to reduce the number of benzo-related adverse events. During Phase 2, an evidence-based practice guideline was developed with input from pharmacists, physicians, and mid-level prescribers from different departments. The guideline will be piloted on the general medicine floors so that I am able to review all benzo prescriptions and consult with prescribers in real time. The guideline will focus on 3 areas of benzo prescribing: indication, dosing, and frequency. It will display indications where benzos may be used and provide guidance on which benzo is most fitting for a particular indication. Based on this, a starting dose for each benzo will be listed, as well as a reminder that PRN dosing is superior to scheduled. For example, alprazolam 0.25 mg by mouth every 8 hours would be a recommendation to a prescriber looking to treat acute anxiety. Pharmacists play a key role in implementing this guideline. For any patient admitted with a benzo as a home medication, a pharmacist will verify the patient's home prescription and usage in order to determine if this medication needs to be continued while inpatient. There will be emphasis placed on reviewing all New Start benzo orders. The pharmacist will ensure the prescription matches the guideline and will intervene when clinically appropriate. All benzo prescriptions will be regularly reviewed to assess if continued use is appropriate throughout the patient's stay. The pharmacist will have the ability to discontinue unneeded PRN benzos when the medication has not been administered in the previous 3 days. Additionally, pharmacists will closely review medications at discharge to ensure that patients are not leaving with a New Start benzo prescription. I plan to continue collecting post-implementation data in order to assess the impact of the guideline within the health system. Continuing data collection will also allow me to identify opportunities for further improvement. I plan to expand the use of this guideline across the entire Northside health system. Based on what I have just discussed, you should be able to answer the following question regarding factors that must be taken into account when prescribing a benzodiazepine. The correct answer is D, all of the above. A special thank you to Megan Freeman, Sarah Murphy, and Melanie Durden who advised me during this project. Thank you for listening to my presentation. Feel free to email me with any questions that you may have. Thank you.